Now we're going to see the vulvar cancer. We have squamous cell carcinoma, melanoma, and Paget disease. These are the order from decreasing, so it's the most common, then this, and then this. The risk factors will include lichen sclerosus, cervical, vulvar intraepithelial neoplasia, obesity, diabetes mellitus, smoking, cardiac disease, etc. For squamous cell carcinoma, the patient has pruritus and vaginal discharge. In postmenopausal women, is secondary to chronic inflammation like lichen sclerosis or something like that, and in woman premenopausal is due to, or younger woman is due to HPV. The treatment would be excision, and the staging would be done on while the patient continues on surgery, and the most common stage is stage 1. The lesion could be ulcerated lesion to a cauliflower lesion. The melanoma is a black lesion, so whenever we have a black lesion or a dark lesion, we need to do biopsy, and this would be positive for the S100 marker. Paget disease presents with a pruritic erythematous red lesion on a white base. Here the marker would be PAS and keratin positive, but negative for S11, for S100. The treatment is either bilateral vulvectomy if there are bilateral lymph node involvement, or just the radical vulvectomy. Then the radiation most of the time is not used, maybe operatively or preoperatively, as well as the chemotherapy. Chemotherapy is done in patients that cannot undergo surgery. Most of the times, for all of them, the lesions, early lesions are like white raised lesions, ulcerated or nodular, and late lesions are cauliflower or hard ulcerated lesions. The treatment for a intraepithelial neoplasia, something like that, high-grade intraepithelial neoplasia, are just topical steroids or laser ablation, vulvectomy, simple or just like vulvectomy, like skinny vulvectomy, and chemotherapy, topical chemotherapy. Corticosteroids alone are not given because we need something else. And the white local excision for a invasive disease, we could either do radical vulvectomy plus lymphadenectomy, or local excision, white local excision of the primary tumor, and then removal of the lymph nodes. Adverse effect of the removal of the lymph node is lower extremity edema. Now the radical or modified radical vulvectomy has a lot of danger in the sense that the patient has a completely major surgery, because other than just removing the vulva, we are removing other stuff like in the same way as in the white local excision. White local excision is just for stage 1A, and here the patient has removal of the vulva, the clitoris, venous pons, perineal body, labia, etc. And a something major is the pelvic extentoration. Pelvic extentoration. Here the patient has not only modified the radical vulvectomy, but also that plus removal of the vagina, ovaries, lower colon, and rectus. So as you can see, these are major surgeries with high morbidity associated with. So we try really to perform these